Good morning, everyone. Respected Dr. Swarnkar, Emeritus Chairperson, Vice Chancellor Dr. Achal Gulati, Chief Advisor Dr. Sudhir Sachdeva, our Pro VC Dr. Vinay Kapoor, Dr. S.S. Jaiswal, Medical Director, and all our senior, eminent and esteemed faculty colleagues as well as students. As is customary, I will begin with a brief introduction of our department. The Department of Hepatology is one of the youngest and probably the smallest departments in the university. The department began in August 21 when Dr. Karan Kumar joined as Associate Professor after finishing his training at the prestigious ILBS institution in Delhi. A couple of months later, I joined him after superannuating from SGPGI, where I had spent the previous 33 years. We were approved for a DM program in 2022, and our first DM senior resident, Dr. Hemant, joined us in March of 2024. A very brief word about what hepatology is for the benefit of residents, since it's a relatively new specialty in which people do not know much about. Basically, hepatology deals with the study of the disease of the liver, gallbladder, biliary tree, and pancreas, covering diagnosis, management, including liver transplantation, and prevention of liver diseases. It is one of the most rapidly growing branches of medicine in terms of innovative medicine, pharmacologic therapies for a variety of disorders, interventional procedures, and surgical procedures. It became separate from the specialty of gastroenterology as recently as 2007, when the first DM program was initiated in PGI Chandigarh. Till date, 9 departments offer this training program in their centers, we being the 7th and the first center in Rajasthan to start a DM hepatology program. Brief word about the clinical profile and the workload in the department. This bar diagram shows you the growth of the OPD and IPD services over the last 4 years, and as you can see, for the last 3 years, roughly about 3,000 per annum is the number of OPD patients that we are seeing. They are super specialty referred patients focused with specific liver disease problems. We are generally managing about 900 to 1,000 inpatients, and our usual bed occupancy is about 10 to 15 inpatients and 1 to 7 patients in the ICU at any given time. Liver transplantation is one of the major activities which has received a real fillip after Professor Nemish Mehta joined the department. Totally, if you see, since till November 25, we have performed about 152 liver transplants, and the year-wise breakup of these procedures is summarized here. Till 2020, about 20 transplants only had been done, and it is since 2021 that the numbers have gone up. And as the orange bars show, this is mainly a living donor-related liver transplant program. We are hardly getting any cadaveric donors, and none at least in this year. In February 2003 to 23, the FibroScan, which is a non-invasive test and it's almost indispensable aid to diagnosis in liver diseases these days, which non-invasively gives you objective serial information on fibrosis as well as fat in the liver, was installed with us, and we have done over 4,700 procedures, and the year-wise breakup is shown here. We also perform specialized ERCP procedures for specific indications like anastomotic biliary strictures after living donor liver transplantation and other benign conditions like post-cholecystectomy, portal cavernoma cholangiopathy, and chronic pancreatitis related strictures. The numbers are as shown here. Coming to our academic activities, the department between 2023 to 2025 has had a total of 34 publications, and 27 of them are in Q1, Q2 journals. The year-wise breakup is shown here. And in this year, we have had so far 16 publications, including 5 in the Q1 journals and 9 in Q2 journals. I'd like to highlight some of the collaborative original articles that we have published in the last few years in the Q1, Q2, and Q3 journals in collaboration with prestigious institutions of departments of hepatology in the country. Which is sorry. Thank you. So these are some of the, we, in collaboration with AIG Hyderabad, ILBS Delhi, PGI Chandigarh, and Apollo Kolkata, etc. We have had these collaborative original articles published. We are also been part of multiple clinical practice guidelines and consensus statements published in on MASLD, that is fatty liver disease, published again in Q1 journals. ACLF consensus, and Dr. Karan and I were both part of it, which is published in another Q1 journal, and 3 national consensus statements on MASLD, hepatitis B, and the futility of liver transplantation. These tables show you all the articles, about 22 that we have published since our last CGR in 2024 April. I am also associated with the Journal of Clinical and Experimental Hepatology and the Indian Journal of Gastroenterology in the capacity of an associate editor, and I review for at least 8 or so index journals. Dr. Karan is a section editor in JCH, a science editor for Indian Journal of Gastroenterology, and also reviews for over 10 indexed journals. Our department has been participating in continuing medical education programs and conferences, and in the period of about 18 months since April 2024, Karan and I have participated in a total of about 30 national conferences in a capacity of speaker, moderator, chairperson, panelist, and once as a guest of honor. So these are the various meetings we have been part of, shown in these tables. And till November 23, this is about 30 meetings here. Some pictorial depictions of our participation. Karan has been quite good at keeping the pictures of the meetings, unlike me. So we have these participations. Our senior resident, Dr. Hemant, has also participated and presented 2 posters in national meetings. This is in August of this year. A poster was presented at the Indian National Association for the Study of the Liver annual meeting, and another one in the upcoming meeting in the first week of December at Amritsar. We have the National Conference of the Indian Society of Gastroenterology, where his poster has been selected as one of the very few presidential poster presentations out of about 450 odd posters submitted for the meeting. The department has also conducted a few conferences, Global Fatty Liver Disease and World Hepatitis Day meetings in 24. Recently, the INAZL has started a series of CME programs across the country, and we conducted one in Jaipur for MASLD, a physician's perspective, and next month we are planning a meeting for sarcopenia in liver disease. This is one of the posters of the flyers of one of these meetings. The department has received various awards and basically participation certificates in the various meetings that we have been part of, as well as mementos that come along with these meetings, which is part of participating in any national meeting. With these few words, I will now move to the case presentation this morning, and I request Dr. Hemant to present this patient, a 50-year-old man with dilated abdominal veins and swelling on both lower limbs. Dr. Hemant.
Good morning, respected dignitaries and my teachers and my colleagues. Today we are discussing a case of a 50-year-old man who presented to us with multiple dilated abdominal veins for the past 7 years and bilateral lower limb swelling for the past 1 month. He was apparently alright 7 years back when he noticed multiple dilated veins over the abdomen, insidious in onset, initially noted over bilateral inguinal regions, gradually progressed in size and length, with new veins appearing over the epigastric region and the left flank, progressed upwards towards the abdomen and up to the right axilla from the right inguinal region, and up to the costal margin from the epigastric veins and the left inguinal regions. These veins are not associated with pain, redness, itching, and did not affect his daily activities. Bilateral lower limb swelling since 1 month, insidious in onset, initially noted over the both feet, gradually progressed up to the ankle on both lower limbs symmetrically, not associated with pain, fever, redness, or any local rise of temperature. There is no history of any dilated veins in other parts of the body, no history of abdominal pain or abdominal distension, no history of dyspnea on exertion, orthopnea, paroxysmal nocturnal dyspnea, no history of decreased urine output or facial swelling, No history of jaundice, altered sensorium, and over-the-counter medication usage. No history of any chronic diseases like hypertension, diabetes, tuberculosis, thyroid disorders, heart disease, and neurological diseases. No history of alcohol or tobacco use, and no history of heavy drug abuse, and there is no history of similar complaints in the family. Past history: 10 years ago, he had an episode of blood vomitings, which required blood transfusions. He underwent an upper GI endoscopy, and bands were applied during the procedure. He was told to have liver disease and was kept on medications. However, he was non-compliant with medications and was not on regular follow-up. Records are not available regarding this illness. 8 years ago, that is 1 year before he developed this dilated abdominal veins, he developed ulcer over inner part of the right leg above the ankle, which was difficult to treat, and he underwent surgical procedure, after which the ulcer healed gradually. And he was conscious, cooperative, oriented to time, place, and person, with height of 183 centimeters, weight of 75 kilograms, with BMI of 22 kilograms per meter square. Vital parameters were normal. Bilateral lower limb pitting edema was present up to the ankle. No pallor, icterus, cyanosis, clubbing, or lymphadenopathy. No stigmata of liver disease like parotid swelling, palmar erythema, spider nevi, or gynecomastia are present. On abdominal examination, abdomen appeared slightly protuberant. All quadrants of the abdomen move equally with respiration. Umbilicus was central, inverted, and round. Multiple dilated tortuous veins were present, most prominent over the right flank, extending from right inguinal region to the right axilla, as shown in the picture. And similar veins with less diameter in the left flank and in the over the epigastric region, extending up to the costal margin. And similar dilated veins were present over the back, below the left rib, and in the center. Superficial palpation: abdomen is soft, non-tender, with no local rise of temperature, and flow of the blood in the dilated veins is below upwards in all the veins over the abdomen. Deep palpation: liver is palpable 8 centimeters below the right costal margin in right midclavicular line. Left lobe of the liver is palpable 6 centimeters below the sternum. Liver is nodular in surface with irregular margins, firm in consistency, non-tender, and moving with respiration. Spleen is palpable 6 centimeters below left costal margin. Hepatojugular reflex was absent, and hernial orifices and external genitalia were normal. On percussion, upper border of liver dullness was present in right fifth intercostal space in midclavicular line, the liver span of 18 centimeters. No shifting dullness was present. On auscultation, bowel sounds were normal. Venous hum hovered over the supraumbilical veins, which is also known as curvilinear Baumgarten sign. Other system examination was normal. No positive findings seen. So in summary, we have a 50-year-old man with multiple dilated abdominal veins, with flow in the veins below upwards, bilateral lower limb edema, enlarged nodular liver with splenomegaly, with past history of upper GI bleed, probably esophageal variceal bleed. So differential diagnosis. Why? So in the audience, anyone can. So the most common cause of dilated abdominal veins are due to portal hypertension, the formation of caput medusae. Portal hypertension causes a prehepatic causes of portal hypertension are portal vein thrombosis, splenic vein thrombosis. Intrahepatic causes are cirrhosis, non-cirrhotic portal fibrosis, and sinusoidal obstruction syndrome. Post-hepatic causes are Budd-Chiari syndrome, inferior vena cava obstruction, congestive cardiac failure, constrictive pericarditis, and severe tricuspid regurgitation. And the other cause of dilated abdominal veins, although upper dilated veins will be more prominent at the upper part of the chest, is superior vena cava obstruction. So how to differentiate between these conditions? First, in portal hypertension, the blood flow in the veins will be away from the umbilicus. Like in a caput medusae, the blood flow will be in all the directions from above and below umbilicus. Blood flow will be in the veins will be away from the umbilicus. Whereas in IVC obstruction, blood flow in the veins is below upwards. And in SVC obstruction, blood flow in the veins will be above downwards. The same is diagrammatically depicted in this picture. So we have a 50-year-old male with blood flow in the veins going below upwards, that is toward the upwards to the cephalad direction. No history of dyspnea, orthopnea, paroxysmal normal dyspnea, or raised JVP. That is, we can rule out superior vena cava obstruction and cardiac causes of the condition. And with a nodular liver, splenomegaly, prior history of likely varicose bleed. So probable causes might be cirrhosis of liver with portal hypertension and IVC obstruction as blood flow in the veins is below upwards. So final clinical diagnosis. The syndromic diagnosis is portal hypertension. Positive findings are splenomegaly with past history of likely esophageal varicose bleed due to cirrhosis of liver with probable etiology of hepatic venous outflow tract obstruction. So with these findings, we wanted to confirm our clinical findings with investigations. With first set of investigations, that is in blood investigations, we found thrombocytopenia, mildly realized bilirubin, and mildly realized INR. On imaging, liver, on ultrasound of abdomen, liver is enlarged with a nodular outline with marked cardiac lobe hypertrophy, with mild splenomegaly and multiple intrahepatic, perihepatic, and mesenteric collaterals. To assess cardiac function, 2D echography was requested, which showed normal parameters. As our patient is, until now we got features of liver cirrhosis, we got a fibroscan done to assess liver fibrosis, as it is a non-invasive test to determine liver fibrosis and steatosis. Fibroscan gives two parameters: liver stiffness measurement, which shows liver fibrosis. Liver stiffness measurement, if it is more than 14 kilopascals, it indicates liver cirrhosis. In our patient, LSM is 25 kilopascals. To assess varicose status of the patient with prior history of likely varicose bleed, upper GI endoscopy showed grade 2 esophageal varices. Modified Paquet, according to modified Paquet classification, which suggests of varices projecting to 1/3 of the luminal diameter that cannot be compressed on air insufflation. With established liver cirrhosis in this patient, we went on to with investigations to determine the cause of liver cirrhosis. In the first, viral markers HbSAg and anti-HCV were negative. Autoimmune markers ANA, ASMA, and serum immunoglobulin were negative, and metabolic risk factors were negative in this patient, as well diabetes, hypertension, obesity, no dyslipidemia, and normal seroplasmin levels. To assess for vascular causes of cirrhosis, triple phase CEC abdominal was requested, and I would like to invite Dr. Purvi to discuss CT findings.
Thank you, Dr. Hemant. Good morning, esteemed teachers, dignitaries, and dear colleagues. I am Dr. Purvi Gupta, first year resident of Department of Radiodiagnosis, and I would be explaining the CT findings of this patient. So the patient was referred to our department for a triple phase CT abdomen and contrast enhanced CT chest. Before I explain the CT findings of the patient, let's take a look what a triple phase CT is. So it involves a dedicated arterial phase, portovenous phase, and delayed phase acquisition. The technique is 100 to 120 ml of non-ionic contrast is given at rate of 3 to 5 ml per second. Then arterial phase is taken at 20 to 35 seconds, in which the arteries are enhanced. In the portovenous phase, which is taken at 60 to 70 seconds, the portal vein and the hepatic veins are enhanced. And in the delayed phase, which is taken at 2 to 5 minutes, in which washout is seen. So it is important to know in which phase of CT should be performed depending upon the pathology that we are looking for. As a normal liver parenchyma is supplied 80% by the portal vein and rest by the hepatic arteries. So the liver parenchyma enhances maximally in the portovenous phase at 65 to 70 seconds. So we would mainly be focusing on the portovenous phase in this patient. These are the axial and the coronal CT images at the level of liver and spleen in the venous phase. Here we can see in the first image, the liver shows diffuse nodular surface with heterogeneous attenuation of the liver. In the second image, we can see the portal vein appears dilated, measuring approximately 15.4 mm in diameter. The splenic vein is also dilated, measuring approximately 15 mm in diameter. The normal portal vein is 15 mm and splenic vein is 10 mm, hence they are dilated in this patient. In the coronal image, we can see the spleen is dilated, spleen is enlarged, measuring approximately 20.8 cm in its craniocaudal axis. These are again axial and sagittal CT images in the venous phase. On the first image, we can see the right hepatic vein and the left hepatic vein at the IVC confluence, suggesting patent veins. On the third image, at the sagittal image, we can, as we trace the IVC, we can see marked area of very short segmental luminal narrowing in the hepatic IVC, measuring approximately 13 mm in length. However, the atriocaval confluence appears patent. The IVC proximal to the narrowing appears dilated, measuring approximately 30 mm in diameter. These are comparative volume rendered 3D images showing a very short segmental narrowing in the hepatic IVC with dilatation of the IVC proximal to the narrowing. And this is a comparative image of how a normal patent IVC looks like. So this is again a axial CT image in venous phase showing intrahepatic collaterals, and the collaterals are also seen in the abdominal wall. This is a CT image showing multiple portosystemic collaterals in the pancreaticoduodenal region and in the lienorenal region. Dilated ascending lumbar veins were also noted. In this axial CT image, we can see dilated azygous veins on the right side and dilated hemiazygous veins on the left side at D10 level of the vertebral body. Normally these veins are not visualized, they are only seen because they are dilated in this patient. In the middle, aorta is seen. In the second image, which is the coronal section, multiple abdominal wall collaterals seen extending from the iliac veins, traversing through the abdominal wall and draining into the axillary vein, which continues as the subclavian vein, thus bypassing the IVC and draining into SVC. Similar collaterals are also seen on the left side, draining into the left axillary vein. This is a volume rendered 3D image. Here we can see collaterals along the anterior abdominal wall and the lateral abdominal wall extending from the groin region up till the axilla, thus bypassing the IVC. Similar but less dilated collaterals are seen on the left side as well. So to summarize our findings, we saw diffuse hepatic surface nodularity with heterogeneous attenuation of liver due to congestive changes. Splenomegaly with dilated splenoportal axis was noted. A very short segmental area of marked luminal narrowing seen in the hepatic IVC proximal to IVC dilatation. Also, right and left hepatic veins were opacified. Multiple intrahepatic, portosystemic and abdominal wall collaterals with dilated azygous and hemiazygous veins were seen. So our final diagnosis was cirrhotic liver with portal hypertension and marked narrowing of the hepatic IVC, suggestive of hepatic venous outflow tract obstruction with inferior vena cava syndrome. Now I would like to invite Dr. Hemant to continue the presentation.
Thank you, Dr. Purvi. So we got to our final diagnosis, that is cirrhosis of liver due to hepatic venous outflow tract obstruction, that is hepatic vena cava syndrome with portal hypertension and grade 2 esophageal varices. Before going to the management of our patient, I would like to discuss a few things about this condition. Hepatic venous outflow tract obstruction is defined as obstruction of hepatic venous outflow anywhere between small hepatic venules up to the entrance of IVC into the right atrium. It might be primary or secondary. Primary if the blockage is intrinsic to the vein, Secondary, if the blockage is due to external compression of the vein. HVOTO is also classified according to the site of obstruction. Sinusoidal obstruction syndrome or veno-occlusive disease, if the site of obstruction is at the sinusoidal endothelium. If the site of obstruction is at the level of hepatic veins, it is called Budd-Chiari syndrome. And if the site of obstruction is at the hepatic portion of IVC, it is called hepatic vena cava syndrome. Sinusoidal obstruction syndrome is due to toxic injury with pyroxene alkaloids, immunosuppressive drugs, or mostly seen in post bone marrow transplant recipients. Budd-Chiari syndrome is most commonly due to post prothrombotic disorders, and hepatic vena cava syndrome is mostly idiopathic and very less likely prothrombotic disorders. Treatment is mostly supportive in sinusoidal obstruction syndrome and defibrillate in very minimal cases. And for Budd-Chiari syndrome, treatment is anticoagulation and recanalization of the vein. Same with hepatic vena cava syndrome, recanalization of the vein and anticoagulation. As our patient is having primary hepatic venous outflow obstruction, the most common causes of this condition are acquired prothrombotic diseases like myeloproliferative neoplasms, antiphospholipid syndrome, hyperhomocystinemia, inherited prothrombotic disorders like factor V laden mutation, protein C and S deficiency, and other factors like oral contraceptives and patients, females in pregnancy and puerperium. We got a thrombophilia workup done for our patient, which showed decreased functional activity of protein C and antithrombin 3, which is consistent with liver cirrhosis, and there are no means to differentiate between liver cirrhosis, whether there is liver cirrhosis or primary protein C or antithrombin 3 deficiency. Coming to the management of our patient, management is first treatment of the etiology, that is IVC obstruction, which is recanalization of the IVC by IVC angioplasty plus or minus stenting, and treatment of complications of portal hypertension, that is varicose bleed, ascites or hepatic encephalopathy. As our patient is having is a prior bleeder with history of varicose bleed, non-selective beta blockers were started for the patient. This is a management algorithm in hepatic vena cava syndrome. In patients with cirrhosis who are decompensated, patient will be advised liver transplant with IVC recanalization, and with patients with cirrhosis who are compensated, amenable for recanalization, angioplasty plus stenting will be advised. When post stenting, in the patients with if they finally end up in decompensated cirrhosis, TIPS, transjugular intrahepatic portosystemic stent will be done, and in patients with worsening liver functions, liver transplant will be advised. I would like to invite Dr. Sidharth from Interventional Radiology. As our patient, we have advised IVC angioplasty and stenting for our patient.
So we took access from the right common femoral vein and did a IVC venogram, which revealed complete occlusion of the intrahepatic segment of the IVC. As we can see in the video, the contrast should have gone into the right atrium, but instead of going into the right atrium, we can see the reversal of flow within the IVC, and a hepatic outflow collateral is also seen in the venography. When we saw the reversal of flow in the IVC, a check venogram was done from the right common femoral vein, and we can see a collateral is seen arising from the right iliac vein. Therefore, because of the complete obstruction of the IVC, the entire lower abdominal and lower extremity blood flow is draining through these collaterals. In the second video, we can trace the contrast material flowing through these collaterals. After multiple attempts, we were not able to cross the occlusion from the common femoral route. Therefore, we decided to change our strategy and took access from the right internal jugular vein and tried crossing the occlusion from the jugular side as well. But we could not cross the occluded segment with normal recanalization techniques. Therefore, we took simultaneous venogram from the right common femoral vein and jugular ends to know the exact location of the occlusion. A 15 mm long segment occlusion was noted in the intrahepatic IVC. In the end, we used sharp recanalization technique to cross the occluded segment. In the video, we can appreciate an attempt is being made with the back end of the stiff wire. After a lot of hard work, we were able to cross the occlusion through the jugular side, and a guide wire and catheter combination was negotiated distal to the occlusion. We can very well appreciate within this video. After successful negotiation through the occlusion, serial balloon dilatation was done using non-compliant high pressure balloons of diameter 16 and 20 mm in the diameter. Despite 16 and 20 mm of balloon dilatations, IVC recoiled back to a diameter of 4 mm, suggestive of a very tight stenosis. So a decision was made to restore the luminal patency using self-expanding bare metal stents. After proper planning, our purpose was to deploy the stent in the stenotic segment and the main challenges were to do the IVC stenting without occluding the inflow from the hepatic collaterals and prevent jutting of the stent into the right atrium. So after precise measurement, we chose self-expanding metallic stent of size 60 mm in length and 22 mm in diameter, and it was deployed accurately. These stents are designed to provide high radial strength and flexibility to handle the natural movement of the body and to tackle with the difficult anatomies. After the stenting, venography was done and we can see a good flow of contrast across the stent. Iliac vein collaterals, which were seen before the stenting, vanished immediately after the IVC stenting, indicating the immediate success of our procedure. During the hospital stay, patient was kept on low molecular weight heparin for 5 days, and at the time of discharge, oral anticoagulation was started to prevent thrombus formation within the stent. Apixaban was given to the patient, 5 mg BD dose. Beta blockers were given for the secondary prophylaxis of the variceal bleed. In the follow-up, patient was asked to visit the hospital regularly at 3 months in the first year and followed by 6 months of interval. IVC stent patency was checked with the help of the color Doppler, and complication of the cirrhosis of the liver and the portal hypertension were also checked. Endoscopy was advised every 6 months to assess the variceal status. Now I invite Dr. Purvi to discuss the imaging after the stenting.
So this is a 3D volume rendered images showing the stent within the IVC. In the sagittal image, we can see patent IVC with stent, and the diameter of the IVC is 16 mm, which is within the normal limit. These are again the axial CT images in the venous phase. On comparison with the pre-stenting image, we can see the congestion within the liver has improved and size of the collaterals has diminished. These are axial CT image showing significant reduction in the collaterals in the post-stenting scan. These are volume rendered 3D images showing significant reduction in the caliber of the collaterals in the post-stenting images. To collaborate our findings with the volume rendered images, the clinical picture of the patient shows significant reduction in the collaterals on the right and left side in the post-stenting images. Now I invite Dr. Karan Kumar sir to take over and present the review of literature.
So, good morning everyone. Now I will just discuss a patient who had dilated abdominal vein for almost 7 to 10 years, had visited doctors twice, once for a variceal bleed, second for a non-healing venous ulcer, and everybody ignored those veins. The first physician just tackled the bleed, did an endoscopy. The second one managed the venous ulcer, did something with the veins, and ignored completely what was there on the abdomen, which were clearly evident. So this case just highlights the significance and importance of general physical examination, which we tend to ignore. A simple look at the abdomen and those veins were crying that there is something wrong, and it was missed for a long decade. So I will try to understand, make the resident aware what is hepatic vena cava syndrome. What are the unusual presentations? They are not usually presenting with bleeds or anything. There can be unusual presentation. How to manage, and after the management, how the patient behaves. What are the long-term outcome of such patients? So first is, what is hepatic vena cava syndrome? Hepatic vena cava syndrome is a clinical condition which is caused by obstruction of IVC. The obstruction, if the obstruction is small, less than 10 millimeter, it is described as membranous. If the obstruction is large segment, more than 10 mm, it is described as segmental. Like in our patient, the obstruction was almost 13 mm on CT scan, and in the digital subsection angiography, it showed even a larger obstruction, almost 15-16 mm. So it was a segmental obstruction of the inferior vena cava. Another major problem with the syndrome is it is mainly seen in our part of the world, India, Japan, Korea. It is not an entity which is commonly seen in the Western world. So everywhere the description, the nomenclature is varied. It used to be called as coaptation of vena cava, obliterative hepatovenopathy, membranous occlusion of IVC. But now a common consensus is to use a single entity, that is hepatic vena cava syndrome, instead of all these terms. How this happens? To answer Malhotra's question, the etiology or the pathogenesis of this disease is still not clear. It is considered that there is some basic pathology second year class. What is virtuous triad? For thrombosis, there has to be intermingling of three things: either the endothelial damage, blood flow, or the anatomical abnormality. So it is considered as all the three things maybe together, maybe some prole of infection at the time of birth, umbilical sepsis and all, which can lead to endothelial inflammation. That inflammation will preclude, ultimately will lead to enhanced thrombotic state, which can lead to thrombus formation in the IVC and lead to further hepatic vena cava syndrome. So now talking about the clinical feature, due to the well-developed collaterals, the patient with this IVC obstruction may be having remain without any symptom. It could be just subclinical presentation. Patient will be having only dilated abdominal vein, and the abdominal vein typical collaterals which open up in this IVC obstruction are the superficial abdominal wall collaterals connecting the external iliac vein to the subclavian, or the vertebro-lumbar azygous pathways from the left vertebral veins to the azygous vein, or the left renal hemiazygous pathway. If the obstruction is below the level of liver, it will be mainly presenting as lower limb swelling, venous ulcers, pedal edemas. If the obstruction is at the higher level of the liver, it will cause, after a prolonged time, it will lead to liver cirrhosis and features of portal hypertension. Rarely, because of the paraspinal veins, they can become enlarged and cause venous compression, and patient can be presenting with nerve neurological symptoms like cauda equina, sciatica pain, and the only sign for clicking diagnosis in this patient will be prominent veins on the abdominal wall. After the management with angioplasty or stenting, this is a very good review from after a 12 years long follow-up. As you can see that after even 10 years with the anticoagulation, stent can remain patent in 70% of the patient. And if you talk about survival, almost 87% of the patient with a simple intervention of angioplasty and stenting can live for more than 10 years. This patient is at the age of 53 years. He has undergone stenting. So going by the data, maybe we can say that we have prevented transplant in him or have delayed transplant in him. So what are the learning points in this case? Always see your patient, examine them. The demonstration of dilated veins in upward flow is clinical diagnosis is sufficient to make a diagnosis of hepatic vena cava syndrome. Early diagnosis can prevent cirrhosis. Even if the patient has diagnosis is made even after the development of cirrhosis, but before development of decompensation, it can be reversed or transplant can be averted. And IVC stenting restores the patency, it improves the quality of the life and removes the stigma. So this is just a patient's testimonial. So, on behalf of Department of Hepatology, I would like to take this opportunity to thank and express my deep regards to all the collaborating departments for their kind cooperation. A special mention and thanks to MGUMST management and CCR reviewing committee. I would also like to thank Department of Intervention Radiology, Radio Diagnosis, our nurses officer, and finally the patient and his family for giving us this opportunity to treat him and serve him. Thank you very much.
So